Okay, so please take your seats and we are going to start. My name is José Gatel from the University of Barcelona in Spain, and my co-chair is Dr. Anne Simon from Ptsd Salpêtrière here in Paris. Welcome to this poster discussion session. The session is essentially, or overall, is about several different comorbidities related with HIV infection. We have 5 presentations or 5 posters to be discussed. I will introduce the first 2, and then my co-chair, Dr. Simon, will do the same for the last 3. So what we can do probably is to use 3 to 5 minutes for the formal presentation, and then we'll have another 5 minutes at least for questions and for the discussions. And we will do the questions and the discussion after each presentation because the subjects are relatively unrelated, so that I think it makes not much sense to wait until the end for the discussion. And so without any further delay, the first poster or the first presentation is going to be about cardiovascular events in HIV-infected patients, whether there are more and earlier. And the speaker is Dr. Stefan Essert from Essen in Germany.
Thank you to the organizers for giving us the opportunity to present our data from the HIV and the Heinz-Nixdorf recoil trial. We all know that the life expectancy seemed to be similar between HIV-positive patients and the general population in the era of CARD. But on the other hand, we see publications showing us that cardiovascular events and strokes and other cardiovascular diseases are more frequent in HIV-positive. So is it really true? We compare cardiovascular events, strokes, and overall survival in HIV-positive outpatients of the HIV-HART study and HIV-negative controls of the population-based Heinz-Nixdorf recoil study, both recruited at the same area. In Germany is the so-called Ruhr area. HIV cases with HNR controls are matched 1 to 2 by sex and age, and cardiovascular events were defined as myocardial infarction and sudden cardiac death, and stroke is defined as both ischemic and hemorrhagic stroke. Here you see on the table 1 the baseline characteristics of the HIV-positive population. And you see that 37% are already in the clinical stage AIDS as baseline, and 90% were antiretroviral treated, and 70% of the patient at baseline have a viral load below the level of detection. Table 2 compares HIV positive with the HIV HNR controls. And you see that active smoking is much more frequent in the HIV-positive population. But the numbers of cardiovascular events and deaths are significantly higher in HIV-positive males, but not in females. Table 3 shows the Cox proportional hazard models. Model 1 is adjusted for age, active smoking, and for men additionally for diabetes. And model 0 is a crude model showing the hazard ratio for being HIV positive compared to the general population. And you see that we have a consistently higher risk for cardiovascular events, strokes, and death in HIV positives. In model 1, we observed a hazard ratio of 4.1 for female and cardiovascular event, as well as 4.8 for male and overall survival. These effects dropped to 3.5 and 3.9 after adjusting for smoking, age, and at baseline and diabetes. Here you see the Kaplan-Meier curves for overall survival and cardiovascular event. Both were stratified by HIV status and sex. And also here you see that the cardiovascular event and the overall survival differ really highly between HIV positive and HNR in male, but not in female. So, putting this all together, HIV positive males have an increased incidence of cardiovascular events, and HIV positive males have a higher mortality rate and get cardiovascular events at younger age than the general population. Thank you for your attention.
Thank you for your data. Now it's the paper is open to discussion. If you like to ask questions and to make comments, please go to the microphone. Yes, please, go ahead.
Italy. How many women were on menopause in your study?
Oh, we don't have so much women inside the study. It were 74 or 5 women HIV positive compared with 140 HIV negative women.
Because the problem is that, as you know, women younger than 50 years old has a lower cardiovascular risk than males one. So your results could be influenced by this.
Yes, this is the first point, very good point. And the other one is the women we compare with each other were even younger than the men. The women were 51-year-old and the men were 54 years old. So there is a difference, but we continue both studies and we will present at the next conferences the results after 12 and a half years, and then we have better data to show if this difference between the gender is really true or becomes really true.
Yes, please.
Hello, Gus Cairns, AIDS Map. I'm over here. Hi. Is this a late diagnosis in the earlier era issue? In other words, 30% of your patients were diagnosed with AIDS, so they had a significant period with very low immune function.
This is absolutely true. Thank you for that question. We make analysis, multivariate analysis. We can show that AIDS patients have a much higher risk, of course, to die. And the other point is they have also much higher risk for cardiovascular events and strokes, both.
Yes, please go ahead.
Hello, thanks for the presentation. Kaveh Manavi, Birmingham, UK. I instinctively agree with you, but recently Q Risk Group, a big group in the UK, looked into risk factors with cardiovascular disease in general population, including HIV, and HIV didn't come as an independent factor for cardiovascular events. What's your thoughts on that?
I think there are many hints that it's an independent factor. We see the CD4-CD8 ratio is influenced, AIDS-defining events. So we see many factors that seem to be HIV-specific to see more cardiovascular events. Another point is we also look in our study for drugs, for example, cocaine use and else, and we see a much higher rate of drug use in our population, not only in EVDU. So we have to look if this also influences the rates of cardiovascular events.
Andrew Carr in Sydney. I was struck by the fact that the men who were positive did much worse than the women who were positive. I can't think of a biological reason that that should be the case, except that they don't care for their health as well. Does that explain the difference in cardiovascular event rates? Perhaps another way of looking at that is, does HIV disease progression and viral load suppression take away the difference between the HIV positive and negatives? So if you adjust for viral load suppression over time, which is a function of adherence and attention to health, does that, because you showed adjustment for baseline, but you didn't, I didn't see an adjustment for viral load suppression over time.
We have done in another presentation, and this is absolutely true, if you are not well suppressed, the risk for cardiovascular events is much higher. We also look for inflammation parameters, but you are right. Perhaps the main reason why we don't see the difference that the women's group is too small, and perhaps we need a longer follow-up to show if there is if we find also such a difference. But we see a difference also in lifestyle of HIV-positive women and MSM in our region. Some risky lifestyles I already mentioned, like drug use, are still also higher in men having sex with men.
Okay, just for the HIV patients that had developed a cardiovascular event, had you been able to analyze the antiretroviral therapy that they have been exposed, so that the events had been concentrated in patients receiving PIs or in patients receiving abacavir, or it was evenly distributed irrespective of the antiretroviral therapy?
To make a solid analysis about this, we have to wait longer because our cohort is not so big as the DID cohort. We have seen some trends, and we have seen, the main point from our point of view so far in our study is as early you start the antiviral treatment, as better it is. So the cumulative antiviral treatment may play a role, but it's even worse if you start very late with the introduction of antiviral treatments. This seems in our cohort so far much more important than the cumulative use of antiviral treatment.
Okay, thank you. Any further question or comment? So if not, thanks a lot.
Thank you.
And the second presentation is about the incidence of Fanconi syndrome and other, I guess, renal tubular problems in patients receiving long-term antiretroviral therapy, including tenofovir fumarate. The presenter is Dr. Nicholas Maitland from Melbourne in Australia.
Thank you very much. I'd like to thank the conference organisers for choosing my abstract for an oral poster today. I don't have a slide, but I have no conflicts of interest to declare. So renal Fanconi syndrome has been linked to tenofovir disoproxil fumarate since soon after the release of the drug in soon after 2000. Just to remind you what Fanconi syndrome is, it occurs when there's leakage from the impaired proximal tubule into the urine of substances normally absorbed back. So the glomerulus is filtering through substrate, and substances like glucose, amino acids, phosphate and bicarbonate are then resorbed into the at the proximal tubule. When leakage of those occur, those substrates appear in the urine, and there is some clinical manifestation which we call Fanconi syndrome. It can vary widely in its clinical severity, to at one end acute kidney injury or acute kidney failure. There is association with chronic bone calcium loss. And the relationship, despite it's long known the association, the relationship with TDF is poorly studied. We may have an opportunity to talk about why. So we performed a retrospective cohort study of patients at our clinic from all patients taking tenofovir between 2002 and 2016. We defined Fanconi syndrome as the presence of normoglycemic glycosuria plus proteinuria plus one of the following: reduced EGFR, we measured it by CKD-EPI, hypophosphatemia or phosphaturia or metabolic acidosis. I'll point out that the model of care in our clinic is for patients to have serum biochemical analysis 3 monthly in the first 2 years of their care. If they're stable after that, every 6 months, and ward test urinalysis is performed half yearly in the first 2 years of care, and then yearly thereafter. The main statistical endpoints we're interested in was we performed a Cox regression analysis of the time to development of Fanconi syndrome with the following covariates: ritonavir co-administration, age, gender, comorbidities thought to increase the risk of chronic kidney disease, hypertension, hyperlipidemia, diabetes, or viral hepatitis. We look at CD4 cell count nadir and baseline EGFR. Just some information about the patient cohort here. We had 1,000 patients, just over 1,000 patients took tenofovir without ritonavir, and about 400 who took tenofovir co-administered with a ritonavir-boosted protease inhibitor. Their age when they started treatment was close to 40 years old. Most of the patients were male. This is a retrospective cohort. This is just the patients in our cohort. They were a fairly early treated group. The CD4 nadir mean, sorry, that should be median, was 355 in the tenofovir only group and 315 in the tenofovir-ritonavir group. Together, this group represented 3,779 patient years of exposure to TDF without ritonavir, 1,637 patient years of exposure to TDF with ritonavir. Very high levels of virological suppression. Very briefly, the results. The full tables are presented on the e-poster or on the poster on the wall, but I'll summarise them here. We found 13 cases of Fanconi syndrome. The mean TDF exposure at the time of having Fanconi syndrome identified was 55 months, 4.5 years. The incidence in patients not taking ritonavir was 1.09 per 1,000 patient years. In those, typo there's those co-administering TDF with ritonavir, it was 5.5. I won't present you the full Cox regression table, but the only significant association with the time to developing SS was ritonavir co-administration with an adjusted hazards ratio of 4.71. Quite significantly, or perhaps most significantly, age, sex, comorbidities, CD4 cell count nadir, and baseline EGFR were not associated with more rapid development of Fanconi syndrome. Just got a Kaplan-Meier graph here of the Fanconi syndrome-free survival. For our comparison, this top blue line is patients not taking TDF. We performed the case finding entirely separate from looking at the exposure. There were no cases in that group. This group here is patients taking TDF without ritonavir co-administration, and this group here is patients taking TDF with ritonavir co-administration. So in conclusion, Fanconi syndrome occurs late. I would describe it as uncommon but not rare. I think 1 to 5 per 1,000 patient years is something that we'll all see in our clinics, particularly if we've got largish clinics. Very significantly, the ritonavir administration increases the incidence approximately 5 times. And really, I think maybe if there's a take-home measure, that ongoing frequent monitoring is required, including in very long-term patients who do not appear to be at increased risk. Thank you very much.
Thank you. Thank you. The paper is open for comments or questions. Please go to the microphone. So just meanwhile, a couple of questions. One is taking into account that some of these cases of Fanconi syndrome, they can develop later on in the administration of tenofovir. Should we expect that with tenofovir alafenamide may occur the same 4 or 5 years from now, or it's a different drug in a sense?
Yeah, I mean, like yourself, any of us that have been around long enough will remember the era in which tenofovir was declared not to affect the kidney. TDF was declared not to affect the kidneys, and in particular, it was demonstrated not to cause Fanconi syndrome. So I guess a certain amount of hesitation to declare a drug free of toxicity needs to be held. But I guess the short-term measures of TAF toxicity would appear to be favourable compared to TDF.
We should at least take a look at it.
Yes.
Okay. Yes, please.
Hi, Sylvia Guilherme from Vancouver, Canada. Did you look or find out any bone abnormalities in those patients that have Fanconi syndromes, particularly osteomalacia?
Sure, I've summarised the data here, and the full data about the cases is on the e-poster. But 2 out of the 15 patients developed clinical bone mineral decalcification. One was osteoporosis, may not have been related. One was osteomalacia and was probably related. All 13 cases had resolution of the glycosuria. They all but one had an improvement in their EGFR, but not all of them returned to baseline.
Have any questions? Yes, please.
Hi, Paula Munderi from Entebbe, Uganda. Thanks very much for the presentation. What sort of monitoring then would you recommend the patients on long-term tenofovir for their...
So this study, we've just looked at Fanconi syndrome, and Fanconi syndrome is not the only renal abnormality taken in patients with TDF, but these cases would have been detected by a dipstick urine, which in most places is $1 or less. So I would suggest that to be done at least once or twice a year. It's a fairly inexpensive test. Even if serum creatinine is not available, all of these cases would have been detected by urinalysis.
Just, you have identified ritonavir as one of the most important factors to increase the incidence. Is cobicistat working in the same way or not?
One of the issues with studying Fanconi syndrome is it occurs late and it's relatively infrequent, so you need a large, long cohort. So we weren't able to look at that in our cohort, and I think it will be some years actually before we're able to get a large cohort to see whether or not the effect is just as significant.
No, but from a pathological point of view.
In terms of the pharmacology, I'm not sure, to be honest.
Hi, over here.
Yeah, the last question.
Hi, Anthony Moyer from UCSF. I'm assuming you looked at the causes of Fanconi, like myeloma and things like that.
Yeah, I mean, these patients were otherwise well. So they all worked up to look at for Fanconi syndrome, but they all developed it while taking tenofovir. It all resolved after stopping the tenofovir. It was a very clear evolution in those patients that were followed up, where the glycosuria and the proteinuria developed first, then the reduction in renal function. So I think it was really quite typical cases, and certainly no patients had any other identifiable causes.
Okay, so thank you.
Thank you.
So we can move to the third paper with Felicia Shaw from California, and she talked about HDL role on cognition in older patients.
Great, thanks so much. And thank you for the opportunity to share our abstract findings today. I am here, of course, on behalf of our co-authors who are listed here, and in particular on behalf of Dr. Makanjuola, who's the first author. And he could not be here today, but he really was the one who led the charge in terms of these analyses as part of his master's program at Northwestern, funded through a Fogarty training grant. So as is well known, neurocognitive impairment remains prevalent in persons living with HIV, and in several studies, cardiovascular risk factors have been identified as a major risk factor for cognitive impairment in HIV. And as persons with HIV age, it's really going to be key for us to understand if and how the contribution of cardiovascular disease to cognitive impairment changes. So to this end, the objective of this particular study was to investigate the association of cardiovascular risk factors with neurocognitive impairment in a cohort of middle-aged and older persons living with HIV at entry into the ACTG A3522 or HALO study. We were interested in two primary neurocognitive outcomes. The first was NPZ4, which is simply an average of the mean standardized Z-scores of the 4 tests that are in the neurocognitive screen used in HALO. And those 4 tests are the Hopkins Verbal Learning Test, TRAILS A and B, and then the WISE digit symbol test. And then the second cognitive outcome of interest was the presence or absence of cognitive impairment, which we defined as greater than or equal to 1 standard deviation below the mean on 2 or more of these 4 tests, or greater than 2 standard deviations below the mean on 1 test. And we used linear and logistic regression models to evaluate the association between cardiovascular risk factors in the HALO cohort and these neurocognitive outcomes. So 988 HALO participants were included in the analysis, which is nearly all of them. There are 1,035 HALO participants. And to give you a flavor of the cohort, you can see that the mean age was 52 years. There were 20% women. About 50% were non-white. A very well-educated group with over 60% having a having a greater than high school level of education, and 90% of participants were virologically suppressed. And in terms of cardiovascular risk factors, you can see some of them listed here. So over a third of participants were on an antihypertensive. Over a quarter of participants were on a statin. The mean HDL was 49 in the group. And you can also see that about a quarter of participants were current smokers, and there were very few, just one current IV drug user. The results using both outcomes were quite comparable, so I'm going to present here the result from the multivariable logistic regression model using cognitive impairment as the outcome. There were several demographic and HIV-related risk factors that were associated with an increased odds of cognitive impairment, including older age, being a woman, Hispanic Latino ethnicity, use of an antidepressant, and also use of an integrase inhibitor, whereas longer duration of ARV use was protective against cognitive impairment. But the only cardiovascular risk factor that we found that was associated with cognitive impairment was HDL. And what we found was that for every 10 milligrams per deciliter higher HDL, there was an 11% reduction in the odds of cognitive impairment. And we also looked at HDL using different cutoffs, and we found that if you had an HDL greater than 50, that reduced your odds of cognitive impairment by 35%. And if you had an even higher HDL greater than 60, that this reduced your odds of cognitive impairment by 45%. And that was independent of demographics, all other cardiovascular risk factors, and also HIV-related factors. So this is really the first in a series of planned analyses looking at cardiovascular risk factors and cognitive impairment in the HALO cohort. And we are very interested in seeing whether the presence of these cardiovascular risk factors in, quote, midlife can actually predict later cognitive impairment and also later cognitive decline. We're also interested in looking at cardiovascular risk prediction scores, including the Framingham Risk Score and also the pooled cohort equations, both of which actually include HDL, to see whether or not they may actually help to identify not just persons at risk of cardiovascular disease, but actually also at risk of cognitive impairment. And then finally, based on the results of this particular study, I think a really key question is whether interventions that raise HDL may actually improve or protect cognitive function in persons living with HIV, and importantly, of course, if so, when is the optimal time for such an intervention? So with that, I will end. Thanks very much.
So paper is over for this session.
Hello, Omar Suet from Argentina. Congratulations. Your results show that integrase inhibitors are associated with worse outcome or more cognitive impairment. Could you elaborate about the antiretroviral history of this patient and why you consider, how you explain this result?
Sure. So I don't know necessarily how to explain the result, but so you know so I'll show you. I think there were about 20%, a little over 20% of the participants at entry were on an integrase inhibitor. And what I can say, I mean, we've looked a little bit preliminarily at potential reasons for this. It looks like the folks who were on the integrase inhibitors had been on ARVs for a shorter duration of time, and we did see that longer duration of ARVs was protective. We also saw that the folks who were on an integrase inhibitor were significantly more likely to be on an antidepressant, also significantly more likely to have Hep C, and significantly more likely to be women as well. All of those, however, were controlled for when we still found that significant effect in terms of the integrase inhibitor being associated with worse cognitive impairment. So I think, at least based on the preliminary analyses that we've done trying to look into this a little bit further, I don't think we have a necessarily great explanation at this point in time, but certainly there's additional analyses that we hope to do to look further into it.
Yeah, maybe some similar bias that we saw in the past with abacavir and cardiovascular disease, maybe a tunnelization, an effect that a select bias for more complex patients using integrase inhibitor on those patients, and maybe this more cardiovascular disease or more risk of cognitive impairment also.
Sure. I mean, I think there are a number of potentially unmeasured, variables here. In addition, we have this variable of antidepressant use. We certainly have seen some recent data coming out that integrase inhibitors potentially are associated with different CNS adverse effects, and those certainly can impact cognitive function. And it may very well be that we're not recognizing that in these individuals and that they're not on antidepressant use, so even controlling for that isn't, accounting for the increased risk of impairment.
Thank you very much.
Please.
Hi, Ken Kunisaki, Minneapolis. Regarding this association between HDL and cognitive function, I was just wondering, exercise is associated with higher HDLs, exercise has been associated with improved cognitive performance. Do you have any measure of whether it's exercise or self-reported physical activity measures that might explain that association?
Yeah, I actually am not entirely sure. There's probably someone in the audience that knows better than me in terms of whether in HALO there are measures of physical activity. I don't believe there are, but certainly if we do have them, we will look.
I have a question. How do you rise the HDL level?
What was that?
How do you rise the HDL level?
Sure. So, as mentioned, exercise is one intervention, diet as well. Smoking cessation has been associated with an increase in HDL. There are certain medications, as the clinicians and patients even perhaps know, in terms of increasing your HDL. Unfortunately, statins are perhaps associated with at most modest, but certainly not in the same way that it reduces LDL. So, increasing your HDL is not quite as easy as reducing your LDL. So I think that will prove to be a challenge, perhaps.
Okay, please.
I think that was my question, more or less. But I could just expand it. I'm wondering if this was more an associative finding, a serendipitous finding, because the medications for raising HDL are very poor in large part. The one that was used for quite some time, the niacin or niacin type product, has virtually been devalued, so to speak. All the major organizations in the United States, the ACP, the AMA, said there's no value to this it may affect HDL, but downstream cardiovascular risk, there's no effect, and they recommend actually discontinuing it patients. So we really don't have a good agent that we can give to the patient to put in the water to help them elevate their HDL. So, I mean, I'm curious how to go farther with this. How you would propose to affect a change of these patients and to show that there may be an effect study. This seems to be more associative.
Yes, so it's definitely an associative study. I would agree with that for sure. But no, I hear what you're saying, and I think that is the challenge in terms of the difficulty potentially in raising HDL. Diet and exercise, those are things that certainly work, and they certainly can lead to an increase in HDL. So I think that's at the least a place to start. But I think it's a good point that you raise.
A quick question.
Yeah, very quick, actually, to comment. Lucette Cizik from Australia. We've actually found that result back in 2013. Have you published already your thing? I think you've published it.
No, this is not published.
So if you want to add our paper in your discussion, thank you. But honestly, so in 2013 in PLOS ONE, we found that effect on MRI spectroscopy. People with better cholesterol, the better type of cholesterol, have a better neural integrity in some of the brain region. So it is associative, but twice I think means maybe it's meaningful.
And it's not just your study, also in the MAX as well.
Very good.
This has also been seen in which HDL specifically also has been associated with less of a decline in cognitive function.
Thank you. Great talk.
Thank you.
Thank you.
So move on the original care, Taishi and support in patients with HIV by, I don't know your surname? Jordan Lake from Texas. Thank you.
Thank you. I'm happy to be able to present these data to you on behalf of the Stop Pain study team. I have no conflicts of interest to report. So as this audience knows, chronic pain is common among older HIV HIV-positive adults and can contribute to both substance abuse and reduced physical function, and non-pharmacologic interventions to reduce pain, improve coping skills, and/or improve physical function may reduce disability and improve quality of life. So we designed a pilot, randomized, 3-arm, 12-week feasibility study of weekly combined cognitive behavioral therapy in combination with Tai Chi and motivational text messaging versus standard weekly support group versus no intervention in older HIV infected adults with chronic pain and substance use. So it's a very specific population. But you can see at the bottom of the screen the 3 randomization arms just for clarification. With the second, the support group arm serving as a control intervention and the third arm serving as a true control group. So our study population consisted of persons living with HIV who were at least 50 years of age, had chronic pain for at least 3 months on most days of the week, and who used substances to control their pain or used prescribed pain medications more than prescribed in the last 3 months. Additionally, participants needed to be able to participate in low-intensity exercise and have a cell phone that could accept text messages. The setting, the study was performed at APIT, which is a community-based AIDS service organization in Los Angeles, California. It was not performed in a medical facility. For our outcomes and assessments, we assessed pain, substance use, and physical function using a variety of instruments. I'm not going to show you instrument-specific results. I'll show you pooled results, so we won't spend too much time on the individual assessments. And because this was a pilot feasibility study that was really designed to inform a larger future randomized controlled trial, it was a small sample size, total of 55 participants, briefly equally randomized across arms, but that prevented more elaborate modeling. So the data I'll show you are the intention to treat analyses of repeated measures at weeks 0, 8, which was the end of the intervention, and 12, which was the 4-week follow-up. So our participants had a median age of 55, 84% were non-white, and about 3/4 were male, with additional 15% self-identifying as cisgender female and 9% identifying as transgender female. You can tell this is a population that had been living with HIV for quite a long time. The median years since HIV diagnosis was 17. However, they were well controlled on therapy with a median CD4 count of 597 and median of 11 years with chronic pain and median of 3 non-HIV comorbidities. 60% were using alcohol or marijuana as their preferred substance, and 42% were also using prescription pain medications to try to control their pain, most commonly non-steroidal agents and opioids. So the results of our studies show that the combined intervention and the support group interventions had significant, participants in those arms had significant increases in the number of days abstinent from the preferred substance in the last 30 days. Additionally, the combined intervention group reported an increase in the number of days abstinent from any substance, whether or not it was preferred. And I can tell you, this was Los Angeles, and 33% of the patients, their preferred substance was methamphetamines. And so we did feel that it was important, and in sensitivity analyses, we looked at alcohol, marijuana, and opioids together versus the stimulant use as preferred substances. Results are similar despite preferred substance. And then, as you would expect, we saw no changes in substance use outcomes among participants who did not receive the intervention. What I think was especially striking were our pain and physical function outcomes. Participants in the combined intervention arm reported significantly greater pain relief from their current medications, which were not escalated during the study period. Combined intervention participants also had improved physical function scores and a significantly lower frequency of reduced physical function. Reduced physical function is a binary variable with a short physical performance battery score of less than 10. And we had a 60% reduction in the number of people reporting reduced physical function. And we saw no consistent changes, importantly, in pain or physical function outcomes for either the control intervention or the no intervention arm. With that, I'll end.
Tao, some questions?
Can you explain to us what do you define by pain? Is just a general pain? Is headache? Is muscular pain? Is pain in the joints?
Patients were asked what types of pain they experienced, but the questionnaire and the screening process started out with, do you experience pain as a subjective measure, however the patient defined it, and then we went through the different types of pain. The most common were osteoarthritis-related pain and peripheral neuropathy-related pain. But so we do have a breakdown of by type of pain as well. But the general definition was participant self-defined.
Please.
Hi, Jeff Berry, Positively Aware Magazine. Very interesting study. So, oftentimes people use marijuana as to control pain. So, we're able to tease that out if people who maybe continue to use marijuana or didn't, and if the reduction in pain was similar. And also, maybe I missed it, but was prescription drug medication reduced, or did it stay the same?
I'll have to look and see if we've yet teased out. We're still doing analyses for this. I'll have to see if we've teased out just the prescription pain meds separately, because it was a combined composite variable to get into the study of using either your prescriptions more than prescribed or other substances. Those were initially lumped together. I'm sorry, your second question was related to marijuana. And so this was a subject of much debate during the study period. Marijuana is legal in California, and most patients had a prescription for marijuana, so it sort of counted as a prescription pain medication. But we did ask the participants why they were using their various substances, because obviously substance use is a multifactorial component. So most participants said that they were using their marijuana for pain relief.
Hello, thank you for a good presentation. I'm Dr. Adezio Ray from Abuja, Nigeria. Now, I found your study interesting because we're doing something similar amongst HIV populations. So my question is with regards to the text messaging. Were the motivational text messaging, were they fixed messages? Were they selected messages from the participants? Did they contribute to the types of messaging they received? And did they vary over the weekly, the 12-week period of the study? Thank you.
Thank you. So we did have a whole series of motivational messages, and each participant got their weekly message at random. So they did cycle through the entire list of messages during the study period. And for this particular study, participants were not involved in the text messaging content, but they were derived from previous studies in this population where the participants were allowed to have input into the content. And then we also asked participants at the end of this study how they felt about the content.
Thank you.
I have a question. Why did you choose the Taiji?
So we surveyed the community. At this community-based organization, I happen to know that a lot of the participants were very frail, and I wanted a low-intensity exercise where we would not have people falling and hurting themselves, but we wanted to offer a variety of options. So we actually surveyed people at the community center, gave them a variety of options, demonstrated what these activities would be like for them if they were participating, and the community chose Tai Chi as the intervention.
Okay, thank you. Thank you. And movement for the last of the list. It's Angela Participe from New York, who talk about capacity to screen and manage mental disease in HIV people.
So thank you to the organizers for inviting me to share this work with you today. I have no conflicts of interest to declare. When we talk about comorbidities among people living with HIV, mental health and substance use disorders are among the most prevalent comorbidities among people living with HIV throughout the globe, and they are consistently associated with suboptimal HIV treatment outcomes. This includes poor adherence to antiretroviral therapy, as well as lack of timely viral suppression. Integrating services to screen and treat for mental health and substance use disorders in HIV care has been advanced as a promising strategy to improve not only mental health care, but also HIV treatment outcomes among this population. However, data on the capacity for HIV clinics to screen and treat mental health disorders are still quite limited. So our study objective was to assess practices for screening and treatment of mental health and substance use disorders in HIV treatment settings in low and middle income countries that are participating in the International Epidemiology Databases to Evaluate AIDS, or the IDEA Consortium. Our sample consists of 95 HIV treatment sites across 29 low and middle income countries that are participating in IDEA. And this is a stratified random sample of IDEA sites. And this sample within each country was stratified by 3 components. So by the location, whether or not the HIV site was located in a rural or an urban setting, by the patient population served, so whether the HIV treatment site served exclusively children or adolescents, exclusively adults, or both adults and children and adolescents. And then finally, by the level of care provided at the site. So whether the site was a health center, a district hospital, or provincial, university, or regional hospital. I invite you to view the poster for a fuller representation of our results, but what I want to highlight for you here today, this demonstrates the combined availability of screening and on-site treatment of 3 different mental health disorders as reported by HIV sites sampled. On-site treatment is defined as treatment that's available either within the HIV clinic or within the same health facility. And you can see here on the bottom, depression, post-traumatic stress disorder or PTSD, and substance use disorders. And starting with the farthest left, that bar represents sites that reported neither screening nor on-site treatment for that specific disorder, followed by sites that reported screening only, on-site treatment only, and then combined screening and on-site treatment availability. And what I want to highlight for you here is that when we look at these results by these 3 disorders, we see fairly different patterns for each disorder. And so when we look at depression, 42% of the sites that we surveyed reported both screening and on-site treatment for depression. However, 27% also reported on-site treatment only. So these are clinics that are reporting that they provide treatment on-site for depression, but they're not routinely screening, or they're not screening their HIV patients within their HIV clinic for depression. When we looked at these results for PTSD, we see a different pattern. And overwhelmingly, the sites we surveyed reported not screening for PTSD. So when we look at screening alone, 81% of sites sampled reported that they did not screen for PTSD in their clinics. When we look at the combined availability, we see that 42% of sites surveyed reported that they provided neither screening nor on-site treatment for PTSD. And then we see here that 38% actually report on-site treatment for PTSD, but again, not screening their client population within the HIV clinic for PTSD. When we look at the results for substance use disorders, and this included both alcohol use disorder and drug use disorders, we see yet another pattern in which 26% of sites report screening and on-site treatment for substance use disorders. However, we see here that 30% report screening only for substance use disorders, so a higher prevalence of screening exclusively in the absence of on-site treatment for for substance use disorders, which is a different pattern than we see for PTSD. So briefly, most HIV treatment sites that we surveyed reported some integration of mental health and substance use disorder services. And as I mentioned, screening for PTSD was less commonly reported than screening for depression or substance use disorders in the HIV clinics surveyed. And screening and on-site treatment was most commonly reported for depression as compared to PTSD or substance use disorders. So what are some next steps and where do we go from here? Well, future work should assess modifiable barriers and facilitators to the integration of mental health and substance use disorder care in low and middle income countries. So what is it that sets apart the clinics that were reporting integrated care from those that were not? And can we learn a bit more to understand how we can further integrate care? As well as the identification and evaluation of optimal implementation strategies to scale and sustain integrated mental health and substance use disorder care with HIV care. So we are fortunate within the mental health community that we do have evidence-based interventions for many mental health disorders. And so this really becomes a question in part of implementation science. How do we get the interventions to the people that need them and in the places that they're already frequenting for healthcare? These data will also inform the design of prospective cohort studies to improve screening and treatment of mental health and substance use disorders among people living with HIV, and ultimately with the goal of improving the health and well-being of this population. So I want to thank my collaborators, the PEPFAR NCD project who collaborated on this work, and the IDEA Consortium, as well as our funders.
So, paper is open for discussion.
So what would be your recommendation would be that HIV clinics should have an integrated care for mental disorders, including screening or treatment, or the patients should be routinely and systematically referred to a mental clinic? So what would be the model you would recommend after that?
Well, I think it depends, and I think it depends largely on the context and the feasibility of various models within the specific setting. One potential model is integrated care, and so as we move towards a more chronic care model of HIV treatment, there's a lot we can adapt in the chronic care model to effectively address mental health. And so to the extent that that's possible, integrated care is one way to increase access to evidence-based services for people that need them. However, if there are referral opportunities, I think referral to care can also be a model that can be put forth. Often referral avenues don't exist. And so in those settings, thinking more about how to integrate evidence-based care within the health setting, I think is often more feasible when referral is not an option.
Please.
Thank you. Laura Chaffee, IRD Cameroon. I was wondering if you could inventoriate a little bit the screening tools, how this screening was done and the treatment, if treatment was standardized medical or other intervention.
Sure. So what we do have is whether or not, what we have data on is whether or not the screening followed a written protocol. And so we can report that out, and the prevalence of screening with a written protocol, as one would imagine, was lower than overall screening. However, we don't have data on the specific tools used for screening in these clinics, or kind of the more specific how it was operationalized in terms of the screening. That's work that we can assess in follow-up studies. In terms of treatment, so we do have data on the reported availability of both pharmacological and psychological interventions in these clinics, and specifically individual psychotherapy or counseling, groups therapy or support groups, and then the availability of SSRIs, benzodiazepines, or other psychiatric medication. So we do have that data. For the interest of time, I didn't report it here, but it is, we ask for psychological treatments disaggregated by whether it's available for depression or PTSD. It's more commonly available for depression. And then for the psychiatric medications, they were all reported to be available on site in at least half of the clinics. It varied by the type of medication, but we do have data on the types of interventions that were available.
Yeah, the data capacity seems to be higher than we expect. So there's two questions. One is the availability self-reported, but what's the coverage? Is it just to very few instead of general universal coverage, or just to very few of the patients? But second, you have kind of answered, it really varies from a very professional intervention to something which is very simple or just counseling. And so, but I think the data seems to be a bit inconsistent, at least to like China or those places, that usually there's a large lack of capacity. So I think we need to be very careful when interpreting the data.
Sure, and I should also note that these are clinics that are participating in IDEA, and so for the overwhelming majority, 80% are in urban areas. And so there are reasons to think that the availability reported here may be different than in more rural clinics or in a primarily rural sample. And so that, we need more work with more data on a representative sample of HIV clinics in each of these countries. And so this sample is representative of IDEA clinics in low and middle income countries, but I don't think we can extrapolate from that so that it would be representative of HIV clinics either in those regions or those countries, and so your point is well taken. In terms of, I think the second point went in line with what I was discussing a moment ago, that there can be a wide range of the types of services and the types of treatment that are available. And so in future work, we want to be able to operationalize in more detail to what extent these services are evidence-based. And that is kind of future work that we're hoping to implement. But
so just one sentence. I worry sending out a wrong message to the workers and the policymakers if we just do not analyze it in details.
Yes, your point is well taken, and this work is analyzed in more detail both on the poster and in the publications we have in preparation, and so this is, for the sake of time, just kind of a very brief overview, and more detailed analysis has been done and is forthcoming.
Thank you.
Just one point. In your slide that described the results, I'm not surprised. I work in a HIV clinic, and I'm not surprised by the substance abuse data, especially the treatment and screening. That takes much more time. And secondly, I mean, involves, because if you're busy with treating HIV, that treating substance abuse is more complicated. But secondly, we don't necessarily have the tools. Now, I can't speak for the other countries, but in the US, for the most part, the substance abuse treatment must be handled in special substance abuse clinics, such, for instance, methadone, which is a common medication. Methadone can be prescribed for substance abuse in only methadone clinics, which are sanctioned by the federal government. So we don't have the availability to treat many of these patients for their substance abuse, for example.
Yeah, I think your point is well taken. And just to reiterate, this is limited to low and middle income countries, although we are expanding this work to look at these same data in high income countries.
Well, I would be surprised that low income countries would be allowed to prescribe methadone, for instance, to treat substance abuse, if in high income countries they're restricted by the government.
Right, and we don't know to what extent pharmacological substance abuse treatments as compared to psychological or non-pharmacologic substance abuse treatments are being reported here. So further work is necessary to understand that in more depth.
Thank you. We have arrived at the end. I thank you all the presenters and the audience.